Dr. Rachael Crystal, thank you and welcome to the Menopause Research and Education Fund. As you know, we do quite a lot of interviews with people like you and academics and GPs and other people who are experts in the world of menopause. And you are a menopause GP up in Manchester. You've also just done an interesting critical appraisal of the literature on progesterone, which you have presented alongside the person who worked with you on this, where you supervised her. Is she a medical student, Eloise?
Eloise, and she's a fourth year medical student at the University of Manchester.
Brilliant. Well, good on her for showing an interest in this, because it's important. Progesterone is an important thing. Anyway, so you've just done this critical appraisal. You presented it at the BMS conference recently. What made you two decide to have a look at progesterone?
Well, I suppose it's a hormone that perhaps doesn't get as much of the limelight as estrogen and testosterone when we come to talking about perimenopause and menopause. And yet, actually, in practice, it does play a really important role for some women. And I think there's more and more questions, quite rightly, being asked by my patients about progesterone, and we're also seeing lots more coverage, I suppose, and questions, articles about progesterone coming up, in particular on social media, and seeing lots of different perspectives, lots of different opinions about how it should be used, when it should be used. And so I thought, when I was supervising Eloise's project last year, I thought this would be a really good topic, and she was really keen to explore this. And I suppose it makes a lot of sense, because actually, you know, when we come to talking about perimenopause and menopause, you know, we talk a lot about estrogen, and certainly, you know, the changing estrogen levels and low estrogen levels then in postmenopause, and the relationship between that and so many of the symptoms that women experience. But actually, we know that progesterone is the first hormone to start to decline in early perimenopause, from what we understand. And
yeah, I think you had actually quite a nice little graph in your thing, didn't you? Which I will attempt to replicate.
Yes. So yes. So fantastic. Oh, you've got better drawing skills than I do.
The squiggly one being the estrogen, the progesterone being the slow decline.
Absolutely. Thank you, Fiona, for attempting that. So yes, so certainly we see that progesterone is probably that starts to decline earlier than estrogen, and we also know that estrogen doesn't, again, decline in a nice smooth line, but instead is often very fluctuant in perimenopause. And sometimes we can have scenarios where symptoms are exacerbated, in particular because of that drop in progesterone, and then the relative high levels of estrogen. So it's not all about low estrogen as the cause of lots of the symptoms, particularly in perimenopause. And so, you know, as a result of that, certain women in particular in early perimenopause might experience some of the symptoms that are particularly related to dropping progesterone levels, which might include anxiety, poor sleep, mood changes, irritability, particularly in that luteal phase, so the sort of couple of weeks before the period. And if we think about what happens in a normal menstrual cycle, so normally we have increasing levels of estrogen in the first half of the cycle, and then when we ovulate, we produce an egg. And left behind in the ovary is something called the corpus luteum, which produces progesterone from ovulation onwards. And the role of the corpus luteum and that progesterone production is to prepare the lining of the womb for pregnancy. And as a result of that, we have significant increase in our levels in progesterone in the second half of our cycle, which then sort of drop off towards the end, and then we have a period. So if, for example, in perimenopause we're not ovulating in the same way, then it may well be that we're not producing that progesterone for some months, if somebody's not missing an ovulation, which we know happens in perimenopause, and generally the production of progesterone from the corpus luteum will be reduced, and certainly for some women that does appear to contribute to some of the perimenopausal symptoms that they might be experiencing. So there's lots of different things to think about, which is why we're really keen to look actually at what the evidence is saying, because certainly in we have patients asking us, should I just be starting with progesterone treatment in perimenopause? And I know, for example, I think in the States that's a fairly popular approach by some doctors in America, and I think in some of the European countries that is used for certain women, particularly women who are struggling with bleeding, and so understandably there's lots and lots of questions about whether we should be doing that. What are the benefits? What are the downsides? So we wanted to look at what the research was actually showing.
So what did you find?
So we found actually that there isn't really a great deal of significant good quality studies looking at progesterone as a standalone treatment for either perimenopause or postmenopause. So Eloise essentially did a big literature search. She identified 179, I think, relatively small studies. And
they are small. I mean, some of them really struck me actually when I was looking through your poster. That I mean, some of them were 8 or 10 people. I mean, it barely rates. They're very small. And I think some of the bigger ones were like 133 or 176 or something. They're not enormous studies.
Yeah, exactly. So the data that we do have is looking at small populations, and when you look at those studies as well, they're quite narrow samples in that they're predominantly women who are well. They've not got any significant other medical problems, and this is a problem in research, across the board, but quite narrow samples. And for example, one of the studies that was looking at sleep benefits of progesterone only included women who didn't have any significant sleep disturbance to start with. So actually, if you think that if we're wanting to improve sleep, because people are having symptoms of disrupted sleep in perimenopause,
you want the people with the problem.
Yes, exactly. And so a lot of the studies, obviously in research, it's hard to recruit participants, and certainly participant recruitment was an issue in quite a few of the studies. So I know that, for example, the 2023 Geraldine Pryor study looking at progesterone monotherapy in perimenopause, there was challenges in recruiting sufficient participants to get the amount of sort of statistical power that's required. And in the Progest study, which actually is I think a really useful study, it's looking at looking at the differences in different doses of micronized progesterone and the impact on vasomotor symptoms, so that they could perhaps achieve FDA approval for progesterone as a monotherapy. But the trial had to be stopped because they couldn't recruit sufficient participants So actually, we're really limited by the numbers available in these studies. And if we think about how guidelines and how evidence comes about, it's all very well, we'll see lots of people on social media understandably sharing really interesting and useful results from studies looking at the benefits of progesterone. But if they've only got 20, 30, 40 or even up to 150 participants, that's not really enough for us to take that into say that's sufficient quality to be looking at putting that into guidelines, putting that into evidence, regardless of the findings, what they come up with. And I think there's also been challenges in looking at, for example, meta-analyses of these randomized controlled trials, because they're just isn't sufficient data that can be powered appropriately. So that's part of where the lack of recognition, I think, of progesterone as part of treatment for perimenopause and menopausal symptoms comes about, because we just don't have the data. In terms of what the data actually does show that we do have, interestingly, a lot of these studies focused on vasomotor symptoms, so hot flushes and night sweats. And certainly there were, some modest benefits compared with placebo for progesterone in both perimenopausal and postmenopausal women. But these benefits are relatively modest if we think about often the benefits that we might see with standard HRT, estrogen replacement, and particularly now, for example, fezolinetant, and the benefits that we see. So certainly there are some improvement in hot flushes and night sweats that were shown in these small studies.
And just reminding people, fezolinetant is the new approved non-hormonal treatment that acts on the sort of the thermostat rather than the hormone system. Just so in case people don't know what it is.
Yeah, no, thank you, Fiona. And I also found, when we were doing this, I found it so interesting that everything was focusing on hot flushes and night sweats and these vasomotor symptoms, because
when people are asking for something entirely different.
Other reasons, yes. And I suppose that's where, for example, I might discuss, have a lot of these discussions. It's around sleep, it's around anxiety. And the reason, I suppose, we use it for those reasons, and for why certainly some women, particularly some like my perimenopausal ladies, early perimenopause, we might start them on a very low dose of estrogen and some cyclical progesterone, micronized progesterone, and they tell me, look, I feel so much better when I'm taking that micronized progesterone. I sleep so much better, my anxiety is so much better, and we know that's because of how progesterone is metabolized. So once we take our progesterone, it's metabolized by the liver, broken down into something called allopregnanolone, which then acts on something called the GABA receptors, which are GABA is a neurotransmitter that acts in the brain and the nervous system that has a calming effect. So it can help with anxiety, it can help with sleep. So it makes a lot of sense that it works that way. And that certainly we see lots of women getting the benefits from micronized progesterone for their anxiety and for their sleep for that reason. Equally, it's also that same pathway, Fiona, that some women really don't get on with micronized progesterone. So we know that there's genetic differences in how we break down that progesterone to allopregnanolone, and then how some of the GABA receptors then receive that allopregnanolone. So we certainly know that there are significant differences, from a genetic basis in those processes. And, we hypothesize that that's potentially why some women really don't tolerate progesterone, potentially why some women experience severe PMDD as well. And then that means that these women might feel very low in mood when they take progesterone. They might sometimes have trouble sleeping, ironically, because that's exactly the opposite of what we think it might work. And they might really struggle with drowsiness and feeling very groggy and sleepy the next day as a result of that mechanism. So there's huge differences in how women seem to tolerate progesterone. And I found it very interesting looking at all of these.
Let me break this in half, though, before you get to doing that. There are two things that come out of that. And one is the, which just went in my head, and out the other one. So I'll start with the one I wasn't going to start with the the growing number of people that are coming in and saying, well, actually, I don't have any menopause symptoms at all, but I really do want to have it for sleep. Is it then something that you would say, well, okay, you don't have to, it's worth trying for the benefits? Do we know whether or not it's okay if they've got sleep issues and things like that to say, okay, yeah, go ahead, take it?
So I suppose I would be interested in breaking that down a little bit further, in terms of, why are they having sleep issues would be my question. So is it that their sleep issues are one of their menopausal symptoms, their perimenopausal symptoms? And I suppose, it would be interesting to know whether that would be the case. But if, say, for the purposes of your question, if we're talking about somebody who has had sleep problems all of their life, and never been a great sleeper, and now maybe they're in their 40s, and they've not really got any other menopausal symptoms at all. They're still having regular periods, even though that's not necessarily a marker of whether someone's perimenopausal or not, but just to say they've not got any other symptoms, this is a long-term sleep problem. We don't really have any evidence that would support the use of progesterone for that reason, that in terms of there haven't been any good quality studies looking at the role of progesterone purely for sleep that are available at the moment. And we probably have more effective ways of managing sleep disturbance, through CBTI, and potentially through sort of the new sort of sleep medications that might help support good sleep. So in that sort of context, no, we don't have good quality evidence that using progesterone would be appropriate in that instance. However, if it was part and parcel, perhaps, that their sleep disturbance was from as a result of perimenopausal symptoms, and was new onset, and perhaps maybe associated with some other mild symptoms, if they were coming and asking whether it's appropriate for them to use progesterone alone, I suppose that isn't in keeping with the current guidance that we have, and it isn't really in keeping with the current evidence base that we have. Talking about needing studies of sufficient numbers. Usually, as well, in those instances, it may be that some of the symptoms are also coming around because of fluctuating estrogen, and I suppose standard practice might be to start them on a very low dose of estrogen with some progesterone. In small, it may be appropriate with an individualized discussion with somebody, that this would be an off-license and under researched area, and it wouldn't fall into sort of current guidelines in terms of prescribing or using progesterone in this way. But it may be that in certain contexts that based on the evidence that we have, that could be feasible, certainly, and certainly we have evidence of short to medium term safety. We don't have long-term data on safety, and we don't really have good quality evidence to back it up. So I can't see that, certainly that's not in the guidelines currently, and I can't see that coming into the sort of mainstream guidance in the near future until we develop and achieve more research and more evidence from that perspective.
I guess proponents of it, many of whom are really quite vocal, would be saying, well, we're just replacing a natural hormone anyway, so what could possibly be the downside? Is that a logical fallacy in some ways?
I suppose that's certainly one argument, isn't it? And I suppose we have to be cautious about sort of extrapolating sort of theoretical mechanisms to practice, to day-to-day practice. We certainly know in lots of areas of medicine there's things that seem physiologically feasible, physiologically appropriate, and then when they get taken, someone thinks, oh well, this seems very physiologically appropriate and very reasonable, and then for example a drug company might then take that to do some trials. We certainly know that there's loads and loads of drugs that don't make it past those first phase trials and experimentations, even though from a physiological basis it would make a lot of sense that it's appropriate. I suppose it's slightly different in the context of progesterone, in this it is a natural hormone. So I do think, if we're thinking as, doctors, as clinicians prescribing medications to patients, I think we have to be confident that we can prescribe safely, and we have good evidence to back that up. So I think it's I think that argument in general, you know, whilst it certainly has some merit, I think, you know, when we're talking about prescribing medications where we don't know what the long-term impact is, we do have to be cautious. And I do think that, you know, we need to share that caution and uncertainty with patients and with women. And I think that's the and this is where it gets really difficult, I think, for women, because you know, particularly with social media, which is brilliant for educating women and sharing things that perhaps they might not hear about from their doctor, they might not hear about from, you know, because it's so difficult to have those quality conversations, isn't it, in the NHS, not through anyone's fault, but that's just the nature of the system. So then we turn to social media to try and educate and inform ourselves, and there's some very, very confident statements made about progesterone and I suppose hormones in general. So I think that can be very difficult for women because nobody knows where to turn and where is that reputable advice, and that, you know, because of the nature of the algorithm, which favors very certain statements, it's understandable that it's very confusing for women, particularly even when there's different clinicians with different decisions and the different perspectives.
Massively confusing.
So yeah. I think the only thing we can be sure about with progesterone in this instance is that we need more research, essentially, and that perhaps different women will respond differently to it. I will say that, you know, from all of the studies that were done, they were looking at different doses. They were looking at using, I think some of them were looking at 200, 300 and 400. There were no significant adverse events that occurred. I think one of them, somebody fainted and had to go to hospital, but it was not shown that that was perhaps related to the progesterone. So there's no significant adverse effects. And some of the studies were looking at we're looking at women over a long period of time for follow-up, but the actual studies were generally only looking at sort of a three month period. So we assume from these small studies that there was no significant adverse safety events, but we just don't really know from that long-term perspective. We think about all the data that we have for estrogen and standard HRT, you know, often that data we're able to look back at 20, 30, up to, you know, 40 years in some instances now. We just don't have that so far with the data with progesterone.
Yeah, there's a question over here. We hear this a lot, actually, sort of that because these are natural hormones and therefore not a patentable product for a pharmaceutical company, that they're not investing in the research on it because there's not enough money to be made out of it. But, you know, there are an awful lot of pharmaceutical companies that produce these hormones, and they are really doing quite well out of them. So there is some money there, but it's an interesting thing, because I don't know that it's necessarily just that. I think there is just a massive underinvestment in women's health in general, beyond cancer. It's virtually non-existent. 0.03% of NIHR funds go to menopause studies since 1993, when I went back and tracked them all. And this is a really rough thing, but basically I looked at any study of the 8,800 or so that have been done since then and funded by the NIHR, and looking for the words menopause or perimenopause mentioned anywhere in the title or the abstract, and there were only 33. So it wasn't a lot of study, and they may not have even actually been looking at anything to do with menopause. They may have just mentioned the word. So we're not highly rated really anywhere, and that's government funding. So I think it's a little bit. I think it's a sort of shallow argument to say, well, there's just no money to be made in it by pharmaceutical companies because they're not looking at it, because there are other sources of getting funding for research. And in the US, the NIH, the National Institutes for Health, is the big funder there of things. And actually, they put in a lot of money recently to menopause and women's health. So hopefully we'll see a turnabout there. So I think I don't think, this is just my personal opinion. Tell me if I'm wrong. I don't think it's as simple to say that pharmaceutical companies aren't interested because it's not going to be a blockbuster drug, because I'm sure if they could find a way of proprietarizing it, they probably would make one. But I think there's just an overall lack of commitment and love of women, really. Am I wrong?
Well, I think that's certainly how it seems, because yes, not all research comes directly from pharmaceutical companies, and yes, there are other sources of funding, and equally, we are seeing other menopause drugs coming out in the last few years. We've had some new estrogen products come out, the Estradiol Conti, for example, and Lenzetto spray by Juvie only came out in the last few years, again, which are hormones which are not, as far as I'm aware, not patentable. Estradiol is not patentable. Utrogestan by Juvie isn't patentable. So I don't know. That's probably not my area of expertise, but it certainly seems like there is potential, but it is just being ignored.
Yeah, we're just not loved. Now, just let me take you back to the PMS and PMDD there, because we had a question that did come in from somebody that plays into that for those people who aren't getting on very, very well. And this is an important one, because it asks, if I can't tolerate utrogestan and I don't want to have a coil, can I put the progesterone in a cream? So to me, there are two things that strike me out of that: the absorption of progesterone in a cream, and if it is progesterone and it is absorbed, surely it would have the same effect.
There's a couple of things with that. I think what we know about progesterone creams is that we've struggled to confirm that there's sufficient absorption for protection of the lining of the womb alongside estrogen HRT. So if you're using that with estrogen, there would be concerns that wouldn't be sufficient to keep the lining of the womb protected against that estrogen. In terms of whether, I know that there are some people that use, particularly in America, who use progesterone creams alone as part of their treatment. Again, I understand that the studies that have been done show very variable absorption in terms of transdermal progesterone in the cream format, and therefore, I don't think we can rely on those for reasonable symptom control, reliable symptom control from that perspective, regardless of whether you're, assuming that you're not needing to use it for endometrial protection. And again, these creams aren't licensed in the UK, and bioidentical progesterone creams aren't regulated either. So that means essentially that anybody can produce these sorts of creams, and they're not subject to the same kind of regulations, testing, safety checks that a regulated medication would be. So I would worry about using those for those reasons alone. In terms of whether somebody would or wouldn't get the same effects, so we certainly know that when we take progesterone orally, the majority of it is metabolized through the liver, and then we have that production of that allopregnanolone and that effect on the GABA receptors. And we know that certainly some women do not tolerate that at all. We know that, for example, as I said, there's a lack of data around that the using the progesterone as a cream, but we do have some data around using progesterone vaginally instead, and when we use it vaginally, we miss out that metabolism by the liver, so we don't produce that allopregnanolone in general, so we don't have that effect on the GABA receptors. There's some suggestions that perhaps there may be a small amount that ends up in the bloodstream and perhaps is then broken down by the liver, so we might have a small amount of allopregnanolone production. We think again, not sure, we need more data on that, but certainly for some women, using it vaginally will avoid a lot of the side effects that they might get with taking it orally. However, the big caveat is we've only got very limited studies. I get a bit of a theme here, isn't there, Fiona? Limited studies looking at the safety of using vaginal progesterone when people are taking estrogen HRT, and how well that can protect the lining of the womb. So very limited data, which means that it's difficult to confidently say that using progesterone vaginally will keep the lining of the womb thin. the one study that we have is looking at using sort of a different dose of progesterone to what we normally would, and it's not entirely convincing that it would be sufficient. And so therefore, if I'm talking to a woman who is really struggling with side effects of using oral progesterone, we would certainly talk about using vaginal estrogen, but we have to talk about the fact that it is off license and we have limited data as to how well it protects the lining of the womb. And therefore, certainly I would always tell my patients that if they have any bleeding, they need to report it very promptly. And sometimes we might need to increase the dose to make sure that the lining of the womb is being appropriately protected. In an ideal world, we might then, if that's the case and we were worried about, somebody might be, some of my patients are very worried about their endometrium being protected. Maybe they've got risk factors, for example, for endometrial cancer, so maybe they're diabetic, maybe they're overweight, maybe they've got a family history of endometrial cancer. So in those instances, it may be more appropriate to look at other progestogen options that they can tolerate, that we know that are proven to protect the lining of the womb well. But I think the key here is that everything really is different for each individual woman. And so we really need to be making sure that we are, yes, using evidence-based medicine, but we need to be individualizing, the advice, the guidance, the treatment recommendations to each individual woman, because there'll be different risk factors, there'll be different sensitivities to hormones, there'll be different responses and different things that we need to consider. So we can't say at the moment that vaginal progesterone is a blanket recommendation for everybody, because we have got to take into account all these different factors and the fact that it would be unlicensed in this context.
Yeah, it's interesting because we had a question come in on that, and with somebody who'd been saying their doctor had basically said, well, they call it off license for a question and there's not enough evidence for you to use it vaginally. But an awful lot of people are in those kinds of circumstances. And when people don't, I couldn't tolerate it, even vaginally, I couldn't tolerate it. I still wanted to murder everybody within about a 200-mile radius of me, which is probably what I'm like most of the time, really. And so if you can't tolerate it and you don't want a coil, what other alternatives do you have? Is the alternative then to say, okay, well, let's give it a go, but just monitor very, very closely, make sure they're having an ultrasound every year or something to make sure there are no changes?
Sorry, if they were using vaginal progesterone, is that what you're saying?
Yeah.
So yeah, I think that's an individual decision that does need to be made with a sort of each individual woman. Again, because it's off license, we don't really have any good quality guidance in whether we should be doing it regular ultrasound scans to monitor the lining of the womb. And there is some suggestion that maybe it offers better endometrial protection. It's very, very small studies because of the way it's sort of localized action. Certainly, I would say we would start off cautiously, monitor for any bleeding, and certainly perhaps if somebody did have other risk factors, perhaps we might think about how we might monitor that. I think it's difficult to give blanket guidelines in these instances because everybody is so individual, but certainly I would, if a woman was happy that it was off license and we have a lack of research in this area, certainly it's where the other options are not appropriate, it would my perspective is it is appropriate to consider that as an option if she feels that's something that's appropriate to her, that's suitable for her and her feelings about things, and we would trial it and monitor things closely and review things closely, but until we have more data, we can't say, oh yes, crack on and use it, everyone should use it vaginally. I think everybody should speak to their own doctor before deciding to use it vaginally, just so that all can be assessed appropriately.
Yes, there's that. Yes, and that, I mean, that might concern a few people who are listening, because I know a lot of people are, and the general thing is sort of like, well, I can chop and change and I can do whatever I like anyway because it's all safe and I can do it. So if it's not, I'm just not even going to ask anybody. I'm just going to be popping it up there because everybody's told me it's safe. But yes, it is definitely worth going back and having a chat with your doctor to say, actually, this is what I'm doing. Is that okay? So in my
and
particular circumstances.
lots of women do, and lots of patients do, and the majority of time that's an individual decision. But I do encourage people to discuss that with their clinician first, just so that everything can be considered.
Yeah, exactly. There was another question there that was, actually there were a couple there. Progesterone as well, because of its ability to help with mood. There was a question there that came in asking about, well, I'm concerned that once I've delivered my baby, I will have a mood crash. Is progesterone the answer there, or is it estrogen?
Yeah, great question. So we know that both estrogen, progesterone, in particular progesterone levels are high during pregnancy, and then certainly they do drop postpartum, and historically higher dose progesterone pessaries have been used for postnatal depression, and are licensed for that indication. There's interesting sort of data in that context as well, because certainly for some women that seems to help, and historically that was used, but it certainly doesn't seem to work for everybody. And the data suggests that there may be some benefit, but it hasn't shown a universal positive result in that context. And I think that certainly for some women, whilst it is helpful, I think we don't have enough evidence at this point to say that women should be using that, before they develop mood problems, to try and prevent that drop. I suppose, actually it's a physiological experience that our hormone levels will change postpartum, and that's a very sort of normal part of the process of having a baby, and then in that postpartum period. Certainly not all women will struggle with mood symptoms. We do know that some women are more vulnerable to what we might call hormonal depression, so PMS, and postnatal depression, and then perimenopausal mood changes. And I think if somebody is worried that they might be more likely to experience postpartum depression, maybe they've experienced it before, having a really good discussion and a plan in place with their healthcare providers to make provisions and make sure that support is there, make sure early monitoring is there for any changes in mood, make sure that woman is appropriately supported, and then treatment decided. But certainly at this point in time, treating prophylactically with progesterone postpartum certainly isn't part of any guidelines or evidence at this point in time. But I appreciate there will be various individual cases, and then certainly are women who've had who've used that as a treatment for postpartum depression with good results.
Okay. Now I know you've got to go, but let me throw one other thing at you, and that was hysterectomies. A lot of people say, "Well, I've had a hysterectomy, so my doctor doesn't seem to think that that I need either estrogen or progesterone anymore." Where's the stance on this, and what happens when it comes to people who've had a hysterectomy who have endometriosis?
Yeah. So certainly, from my experience, for some reasons, it seems that some women seem to benefit with using progesterone following their hysterectomy. And I, in practice, I see improvements often for mood and for sleep. But we don't have any evidence in this context. So there certainly is an off-license prescribing scenario. It's not in the guidance. And certainly does need to be considered on an individual basis. So, you know, we don't know. If we think that we know that a lot of the, you know, the risk that we worry about with HRT are around that very small breast cancer risk, which is minimal, and we know that often it's been overinflated in the media. We think that body identical progesterone doesn't have that same level of risk as the synthetic progestogens, but we probably need more long-term data to be more confident in that that research in terms of the quality of that study based on the E3N study. We probably need longer term data to have the same sort of level of confidence in it to say that natural progesterone doesn't have that same breast cancer risk over the long term as the synthetic progestogens. So in terms of using it post hysterectomy, you could argue that perhaps we could be slightly increasing somebody's risk of breast cancer by a very small amount if they were taking it long term compared with not taking it. But we have to balance that against quality of life, against symptoms, sleep, mood, how somebody's feeling. Does it help them, you know, live a healthier life because they're sleeping better, they're able to exercise more? You know, we just, you know, we don't know. So I think we have to consider that on an individualized basis. In terms of, I think I forgot what in endometriosis you're asking about. What we do know. So yeah, endometriosis. So certainly after a hysterectomy for endometriosis, we would normally discuss or offer progesterone, and that's in the British Menopause Society guidance. The reason for that is that there is always the possibility that even though somebody might have had their womb removed and any endometrial deposits removed, we know that we can get very, very tiny deposits of endometriosis that may not be, you know, visible at surgery. And so there is that theoretical risk that if we were to then give estrogen alone, then that could stimulate any remaining endometriosis deposits, which first of all could cause problematic symptoms, you know, like pain, which we don't want to be doing. And secondly, there is a very, very theoretical risk that if you were to give, you know, estrogen HRT for a long period of time alone, then in theory that tissue could develop and become thickened and transform into endometrial cancer. It's a very, very theoretical risk, and it isn't really one that's seen generally in practice. And, you know, the research, you know, the evidence does recognise that, but because of the potential impact on symptoms and the potential impact on you know, that cancer risk, it is recommended that the progesterone is considered as you know, and certainly often used post hysterectomy for endometriosis.
Brilliant. All right, now quickly going back to you to your study with Eloise, or your appraisal with Eloise. What are your take-home messages out of that then before you disappear for the rest of your day?
Yeah, I think some of the take-home messages, certainly from looking at that, is that, you know, the evidence is supporting. You know, I think what, you know, as clinicians we might see in practice, in that for some women progesterone may offer some benefits, but we just don't have the data yet for that to be translating into guidelines, into recommendations that, you know, blanket recommendations for all women. And I think we can be reassured that certainly in the short term, you know, and based on, you know, how we know what we know about the action of progesterone, and, you know, there's lots of other actions of progesterone that we haven't talked about today, that certainly in the short term it seems as if it is a safe option. But we do need more data. We do need to be able to more confidently, you know, if we were to get to a point where, you know, say we did develop the bigger studies that were to show sort of a positive benefit on a wider scale, we need to be more confident in long-term safety, and, you know, what, you know, those long-term, that there's no significant long-term risks in using it, you know, particularly postmenopausally when we wouldn't naturally have that progesterone there. You know, we know it's a natural hormone, but, you know, it's not necessarily natural to be using it in this way. And I'm not saying that's natural just because it's not natural, it's not right, but we do need that data to be able to have that as a you know, a general recommendation.
It's an interesting one actually, because the person who was asking the question about the lack of research and because of commercial interest and things like that, we need to get researchers actually interested in asking these questions and asking for the money to do it. And we are 51% of the population. This is where I get on my high horse. This is where I go read my goddamn book. We need to be advocating for more money to go to this. We need to be actively encouraging researchers to say, oh, hang on a second, this is 51% of the population. They are living longer. They are starting to do these things. We need to be looking at this, and they need to be then putting in the grant applications to do this work, because frankly, we deserve it.
Yeah.
May I say?
Yeah, 100%. I think the other sort of non-direct takeaway from this is that we do need to be, you know, I think as clinicians, doctors, we need to be listening to individual women more. And, you know, if somebody says, you know, progesterone really helps me, we need to be recognizing and acknowledging and validating that, because certainly we do have this small amount of data which supports this. And I certainly do know that lots of women will come to me because they've, you know, been told that that's not true. You know, progesterone doesn't help you sleep. You know, progesterone is just there to protect the lining of the womb. You don't need it. And I think that can be really, you know, really damaging.
Dismissive.
I think. Yes. So I think, you know, certainly we've got this promising data, and that reflects the fact that, you know, certainly lots of women do benefit from it, but we need more research. You know, I think that absolutely needs to come in the future. So hopefully in 10 years' time, we might be having a different conversation about this, Fiona.
Well, hopefully we can get it done a little bit quicker than that, and that would be a nice thing. So, I mean, if people do want to see these things done, support the Menopause Research and Education Fund, because that's what we're there for. We are there to advocate for research and support research, and hopefully raise money so we can actually fund the research ourselves. So if people want to see research like this done, please donate to the Menopause Research and Education Fund, because that is what we would like to fund. We are here for you and your future health. I should have got a job in advertising, shouldn't I? That was pretty impressive. I impress myself sometimes. But in the meantime, between now and 10 years and getting something useful done, where do people find you, should they wish to find you, Rachel?
Yes, so you can follow me on Instagram at Dr Rachael Crystal and on LinkedIn, and you can also check out our website at Manchester Menopause Hive, where we've got various articles and pieces of information that are evidence-based, that women might find helpful to have a look at and have a read of.
Brilliant. Look, thank you so very, very much for that. It is such a big topic, progesterone, isn't it? I mean, we really need to go back and have one of those conversations where we start right from the very, very beginning, going what it is, what it does, how it does it, and then sort of build it out from there. I feel like I need to have the Progesterone 101 refresher course after that. But thank you very, very much, and hopefully we will speak to you again in the not too distant future. And big congratulations to you and to Eloise. Well done.
Oh, thank you so much, Fiona. Thank you.
Thanks.